Welcome back to our series on antimicrobial approaches to gram-negative bacteria. Today we'll be discussing the second chapter, Basics of Antibiotics. So in this chapter, we'll be discussing about the pharmacokinetic and pharmacodynamic properties of some of the antibiotics which we use routinely, their penetration into the different organs, the side effects, and also important drug interactions. The management of carbapenem resistant infection will be discussed separately in another chapter. So this is the antibiotic ladder which we discussed in the last episode. Just a recap. So if your gram-negative bacteria is resistant to third generation cephalosporins, that is ceftriaxone, ceftazidime and ceftriaxone, but susceptible to fourth generation cephalosporins like cefepime, then it is a AMC producer. If your gram-negative bacteria is resistant to both third generation and fourth generation cephalosporins, but susceptible to a beta-lactamase inhibitor, beta-lactamase inhibitor, then it is a extended spectrum beta-lactamase producer. Then if your bug is resistant to carbapenems because of the enzymes, then the enzymes are called carbapenemases. And carbapenem resistant bacteria can be managed by different other group of antibiotics or with a different BL-BLI combinations which we'll be discussing in the subsequent chapters. So besides beta-lactams, there are other group of antibiotics which will act on the protein synthesis and DNA. For example, aminoglycosides, amikacin, plasmomycin is a new aminoglycoside which is available, useful in treating some of the carbapenem-resistant enterobacteriaceae. Then we have quinolones. Then you have antimetabolites like cotrimoxazole, which is a combination of sulfamethoxazole and trimethoprim. And then we have tetracycline group, including glycycyclines, doxy, mino, tigecycline, iravacycline, and nomadacycline. So most of the times when we go to the rounds and if the patient has infections, these are the important questions we really want to ask bedside: which antibiotic to give, how to give, what is the dose, and what is the dilution, over what time we should be giving antibiotics. So the PKPD principles, to make it very simplified, the antibiotic will be either concentration dependent or it will be a time dependent antibiotic or both. So if your antibiotic is concentration dependent, that is higher the concentration, more bactericidal it will be. So you want to give antibiotic to reach a peak. For example, aminoglycosides. So you want to give a single dose a day and full dose at one time so that it will reach the peak. The side effects of aminoglycosides will again depend upon the trough concentration. So activity will depend upon the peak and side effects will depend upon the trough concentration. So the best way to give aminoglycosides is single dose once a day. Whereas antibiotics like beta-lactam antibiotics, which will depend upon uh, uh, time above MIC. So it will be basically depend upon the time of antibiotic, the time above MIC, the antibiotic is there in the blood. So it has to be given in a slow infusions or continuous form. So beta-lactam antibiotics are usually time dependent. So you want to give it multiple doses and you want to give it over a period of 2 to 3 hours. Sometimes you can give it to 24-hour infusion also. But in tropical countries like India, the room temperature is quite high. So most of the antibiotic stabilities are studied in the room temperature of 20 to 24 degrees. You won't find many studies in 30 to 37 degrees, which is a common temperature in our wards. So if the patient is in ward and without air conditioning, the hanging times, it is not good to give an antibiotic over 24-hour infusion. It is better to restrict the antibiotic infusion time to 2 to 3 hours. So once we choose the antibiotic, this is how you have to write a instruction of antibiotics. So you have to write the route of administration, what antibiotic you want to give, what is the dose of antibiotic, and what is the dilution. This is important. Many of the beta-lactam antibiotics, if you give it along with a ringer lactate, the beta-lactam ring can be broken. In some antibiotics like ceftriaxone, they actually have a EDTA, and ringer lactate will have calcium, so that can actually get precipitated. So it is important to choose the right fluid to dilute the antibiotic. Some antibiotics like cotrimoxazole should be diluted in 5% dextrose. They will get precipitated with a normal saline as well. And then you have to write the infusion time, how much time you want to infuse. You can infuse over 1 hour, or beta-lactam antibiotics we prefer to give it in a longer duration, probably 2 to 3 hours. And the frequency of antibiotic administration. Avoid writing IV antibiotics like OD and BD, because many times the OD can be confused with QID. So it is always better to write Q8 hourly, Q6 hourly. So this is the right way of writing antibiotic in a prescription note. So let us discuss some cases. This is a very common case you see in India, enteric fever, and you can see that the bacteria is susceptible to ceftriaxone, it is susceptible to meropenem, and it is susceptible to azithromycin and cotrimoxazole. You can choose any of them, but why there is no susceptibility mentioned for piperacillin-tazobactam? This is important. One argument can be there are no CLSA breakpoints, but the reason is piperacillin-tazobactam doesn't have good intracellular penetration, whereas ceftriaxone has a moderate intracellular penetration. Meropenem has a great intracellular penetration. Azithromycin actually concentrates intracellularly, and cotrimoxazole will have almost 1:1 intracellular and extracellular penetration. So thing is, enteric fever caused by Salmonella typhi, this bacteria is both intracellular, extra. It's not an obligate intracellular. It is both intracellular and extracellular. So drugs like carbapenems or ceftriaxone, they will rapidly kill the extracellular bacteria, but they will kill the intracellular bacteria slowly. Azithromycin concentrates inside the cell, so azithromycin will kill intracellular bacteria, whereas cotrimoxazole can kill both intracellular and extracellular bacteria. However, cotrimoxazole has a poor PK/PD. It is an antibiotic which binds to proteins a lot. So if the patient is very sick, hypoalbumemic, and there is a extracellular fluid, then probably cotrimoxazole is not a great choice. But however, if the patient is stable, you can use cotrimoxazole as well. Whereas piperacillin-tazobactam doesn't have good intracellular penetration, so it is very difficult to cure typhoid by giving piperacillin-tazobactam. Even the patient will initially respond to the treatment, but it is difficult to cure the infection. So in this patient, you can choose either azithromycin or ceftriaxone or cotrimoxazole. Let us look into ceftriaxone, right? Ceftriaxone is actually a very common antibiotic which we use day in and day out for enteric fever, for leptospirosis, for gram-negative bacteria which are not AMC or ESBL producers. So ceftriaxone is very commonly used antibiotic. It is a highly protein binding drug. So if you have a patient with hypoalbuminemia, the free drug levels of ceftriaxone will be high. That can lead to a rapid clearance of ceftriaxone. So especially if the patient is very sick or patient is obese, overweight, it is always better to give a twice daily dosing there rather than OD dosing. But you can give either OD or twice daily dosing. In meningitis, we give Q12 hourly. In patients who are very sick and obese, you might have to give it Q12 hourly. The important thing about ceftriaxone, again, it contains EDTA. So if you mix it with RL, it will precipitate. Most of the times we know it. We don't usually mix any antibiotic with RL, but then many times patient will have a same cannula. You'll be using a Q site, something like this, and the choice of fluid, now we are more and more discussing about ringer lactate being significantly better compared to normal saline. Normal saline causes hyperchloremic non-gap metabolic acidosis. It can damage the glycocalyx, and if you see a lot of studies where there is, at least there is trend towards mortality benefit with ringer lactate, even though it is minimal mortality benefit, it is statistically significant. So we are preferring more and more ringer lactate over normal saline in our patients. We are resuscitating with ringer lactate. Just imagine a patient being started on ceftriaxone in emergency, and you are running ringer lactate. Both are going through a same Q site. So in pediatric population, there are some case reports where it can really precipitate and can cause pulmonary embolism as well. But in adults, at least because of this precipitation, the amount of dose you are giving is getting wasted. So probably you are underdosing the patients if you are running RL and ceftriaxone through the same Q site. Ceftriaxone, like any other beta-lactam antibiotics, can cause hepatitis, interstitial nephritis, thrombocytopenia, and sometimes allergic reactions like DRESS. If you are using ceftriaxone for long duration, especially infections like non-typhoidal salmonella, or for example, typhoid also will require at least 2 weeks of antibiotics. In the long duration of treatment with ceftriaxone, there is a higher risk of C. difficile, and also there is a risk of biliary sludge in prolonged use. What about cotrimoxazole? Cotrimoxazole is again a great antibiotic. It can be used for many indications. We use it for the treatment of PCP. We also use it for the treatment of melioidosis. You can use it for enteric fever. You can use it for pneumonias. You can use it for UTIs, treatment of nocardia, non-tuberculous mycobacterial infection, for the treatment of toxoplasmosis. So there are many indications. Cotrimoxazole covers many bacteria but not Pseudomonas, and it doesn't have any anaerobic coverage. So two important for a spectrum where cotrimoxazole doesn't cover anaerobes and Pseudomonas. This is something to remember. So the mechanism of action of cotrimoxazole is it is an antimetabolite. So it will make bacteria deficit of folate for the bacteria, so the bacteria will not be able to proliferate. Now cotrimoxazole two components, one is sulfamethoxazole, one is trimethoprim, and cotrimoxazole inhibits the proliferation of cells. Because of its mere mechanism of action, it can actually cause pancytopenia. So patients with cotrimoxazole can develop cytopenias, isolated granulocytopenia, thrombocytopenia, anemia, or pancytopenia. All types of cytopenias are possible. Again, the sulfamethoxazole component of cotrimoxazole can actually lead to sulfa allergy that can manifest as a immediate drug rash, or that can also manifest as a DRESS syndrome, that is after 1 or 2 weeks of giving antibiotic, patient can develop eosinophilia and drug rash, and that can also manifest as severe hepatitis and sometimes landing up in a secondary HLH. What about trimethoprim? Trimethoprim is very similar to trimethoprim. Trimethoprim is nothing but a potassium sparing diuretic. So trimethoprim is basically a potassium sparing diuretic. It inhibits the aldosterone pathway. So it causes little bit of hyponatremia, hyperkalemia, severe metabolic acidosis, um, and diuresis. So if you are having a patient with hypokalemia with fluid overload, and you need an antibiotic to give, probably cotrimox is a good choice because it causes some diuresis as well. Okay. So hyperkalemia related to trimethoprim can be antagonized by giving fludrocortisone, because it is the same site where trimethoprim is also acting. Cotrimoxazole can inhibit the secretion of creatinine from the proximal tubules. So the moment you give cotrimoxazole, there can be small spike in creatinine ranging from zero point 0.1 to zero point 0.3 milligrams per deciliter. You should not be worried about a slight rise in creatinine. If it is jumping from 1 to 1.3, it is more likely to be pseudo AKA. So don't worry about it unless it is gradually progressing. One of the most important aspect we already discussed is protein binding of cotrimoxazole. Because it is a protein bound drug, if you are giving some other medication which also has a high protein binding, that can lead to drug interactions. For example, if the patient with cotrimoxazole is on warfarin, that can lead to increased free drug levels of warfarin and bleeding. Another interaction with metformin is very important. It is also because of the protein binding ability of cotrimoxazole, especially in patients with infected with HIV. So patients infected with HIV, we use cotrimoxazole. Many of these patients will be on a dolutegravir based regimen which has an interaction with metformin. Dolutegravir can increase the drug levels of metformin. So if you introduce cotrimoxazole in between dolutegravir and metformin, so dolutegravir is already increasing the drug levels of metformin. Cotrimoxazole, because of its protein binding ability, again increase the drug levels of metformin. So it can actually lead to a metformin associated lactic acidosis. This might seem very rare, but in our clinical practice we see it very commonly when the patient is on dolutegravir, and if the metformin doses is given in the tunes of probably 1 gram per day, and if you introduce cotrimoxazole there, it can actually lead to a metformin associated lactic acidosis. Again, the IV preparation of cotrimoxazole, it's a very alkaline and very thick, so you have to kind of dilute it in lot of fluid. So if you are treating PCP, probably you are adding 1 liter of extra fluid. So cotrimoxazole, if you are giving as a tablet, it has a diuretic action, but if you are trying to give it IV, you are adding a lot of fluid because of the amount of dilution you require to administer cotrimoxazole. If you don't give this much of fluid, it can lead to precipitation, and it can also lead to crystallization of cotrimoxazole in kidney. The risk of AKI will be higher. It can also lead to a bad thrombophlebitis. So it has to be diluted in 5% dextrose. And once you reconstitute cotrimoxazole, you have to see if there is any precipitates are there in the fluid which you are hanging besides the bedside of the patient. So let us move to another culture report. It's a recap. So it's an E. coli which is resistant to ceftriaxone, resistant to cefepime. So resistant to both third and fourth generation cephalosporins, but susceptible to piperacillin-tazobactam. So it is an ESBL E. coli. You can choose either carbapenems or you can choose the piperacillin-tazobactam. So we used to give piperacillin-tazobactam for these patients till the time this trial came. So the trial is Merino trial, which compared piperacillin-tazobactam with meropenem head to head. Here piperacillin-tazobactam was given at the dose of 4.5 grams every 6th hourly. It is a little bit higher dose than what we normally sometimes used to give. At least 4.5 Q8 hourly is not rare. Many of the times that's what we give. So 4.5 6th hourly piperacillin-tazobactam was compared to meropenem 1 gram 8th hourly, and it is found that there is a very significant mortality difference between piperacillin-tazobactam and meropenem in patients with bloodstream infections with E. coli and Klebsiella. Most of the patients in this study were E. coli. So the mortality difference was quite significant. The mortality was around 88%, survival was around 88% in piperacillin-tazobactam, uh, whereas 97% in patients receiving meropenem. So one might say that we are using piperacillin-tazobactam for so many years and we didn't see such a difference in mortality. But you know, to in a clinical experience to detect this kind of mortality difference is very difficult because 88% of the times the patients are still improving. So to pick up that 12% who are not improving is not very easy. So clinical experience might not be good enough, and there are very good reasons why piperacillin-tazobactam can fail in these patients with high load infections. We have already discussed that tazobactam is a suicidal inhibitor, so it is prone to inoculum effect. So if you are giving very high dose of if the bacteria is producing very high dose of extended spectrum beta lactamases, the tazobactam might not be enough to protect piperacillin. At the same time, there are some PK/PD differences between piperacillin and tazobactam. So the half-life of tazobactam is lower than piperacillin. So if you are spacing the doses, especially if you are giving 8 hourly, the tazobactam levels can actually go below the threshold where it might not be able to protect the piperacillin, and that might lead to a clinical failure. And then again, some of the ESBLs like CTXM beta lactamases, the tazobactam might not be great, that much effective. So from this study, it is very clear that patients, if the patient is having severe infection, especially with bacteremia, meropenem is much better than piperacillin tazobactam. The counter argument is if you keep using meropenem for all the patients, it will obviously lead to carbapenem resistance. So what is the option? Can we use piperacillin tazobactam only? Uh, uh, so so many of the times these are the bedside discussions, you know, especially when someone is giving Q8 hourly, we tend to like ask probably you should be giving Q6 hourly, and there could be counter argument that the study, there is a single study which might not be might not good enough to change your routine practice, or the studies done in Western countries might not be applicable for India, and the patient population there might have a higher weight band compared to what Indians are. This is all true, but the study is conducted in Singapore. 40% of the patients are recruited from Singapore. I don't think the body habitus of Singapore is much higher than patients in India. So even the 6 hourly dosing is failing compared to carbapenem. So I don't see any reason why we should give piperacillin tazobactam at a doses of 8 hourly. So all the patients, if you are still choosing to give piperacillin tazobactam, I think it is better to give 6 hourly dose rather than giving 8 hourly dose. So, so this is the argument now. We are saying that carbapenems are much better than piperacillin tazobactam. There is a mortality benefit, so all the patients should be on carbapenem. But then, definitely this will lead to carbapenem resistance eventually. So, do we have any other option which might help us in not using carbapenem? So, as a carbapenem sparing agent, and there is a new antibiotic called Cefepime-enmetazobactam. We have already discussed about enmetazobactam. It is also a beta lactamase inhibitors, first generation beta lactamase inhibitors. However, its ability to bind beta lactamases is much better, and the affinity for beta lactamases is much better compared to piperacillin tazobactam, and it has been head to head compared with piperacillin tazobactam in a trial called ALIUM, which included the patients with complicated urinary tract infections. So cefepime tazobactam at the doses of 2.5 grams Q8 hourly is compared against piperacillin tazobactam 4.5 grams Q6 hourly, and it is found that cefepime tazobactam is superior to piperacillin tazobactam in overall success, clinical cure, and microbiological eradication. So after Merino trial, there was a discussion like, are we falsely labeling the resistant isolates to piperacillin tazobactam as susceptible? So they have actually revised the clinical breakpoints for piperacillin tazobactam. So they have initially anything less than 64, more than 64 used to be resistant for piperacillin tazobactam. So they have bring down the clinical breakpoints. Only the isolates with a MIC of less than 8 were labeled. The subsequent MIC to say susceptibility is made into 8. So piperacillin tazobactam we should be giving only if the MICs are less than 8. So, but at the same, this trial, ALIUM trial, was done before the change in clinical breakpoints were there. So one of the criticism is probably the isolates which are which are otherwise resistant might be labeled as piperacillin-tazobactam in the study. So there was a post hoc analysis in patients with a MIC of less than 8 and less than 16. Here also cefepime-enmetazobactam has done much better than piperacillin-tazobactam. So cefepime-enmetazobactam is definitely a good alternative. It has a mechanistic reason, because of the limitations of piperacillin-tazobactam, especially with high inoculum, and because of the PK/PD differences between piperacillin-tazobactam. Probably cefepime-enmetazobactam is definitely superior to piperacillin-tazobactam. Only problem is cost. Cefepime-enmetazobactam at present will cost around 5,000 rupees, Indian rupees per day, whereas piperacillin-tazobactam will be much cheaper. But this is definitely a good alternative. Let's discuss another case. This case of Klebsiella pneumonia with pus culture. You can see that it is resistant to third generation and fourth generation cephalosporins, and resistant to piperacillin-tazobactam also, susceptible to carbapenem. So probably this is the case again. You can use carbapenems or cefepime-enmetazobactam. Cefepime-enmetazobactam at present is only approved for UTIs. You can use it even for other infections, but the approval is only for UTIs. So at this point of time, probably the choice of antibiotics will be one of the carbapenems. So we have three carbapenems: meropenem, imipenem, ertapenem. You can see that ertapenem has a very high protein binding. We have discussed this in the last class as well. So because of a very high protein binding in a patients with hypoalbuminemia, the free drug levels of ertapenem will be high. That will lead to a rapid excretion of ertapenem, where it can fail. So one of the biggest advantage of ertapenem is the longer half-life of 4 hours. Because of this reason, we are actually able to give this in a single dose a day. But because of the high protein binding, if you are giving in patients with hypoalbuminemia, there is a risk of failure, and there can be higher mortality. So you avoid ertapenem in a very sick patients. Avoid ertapenem in patients with hypoalbuminemia. Among meropenem, imipenem, and ertapenem, imipenem actually has a high penicillin binding protein to affinity. It is effective against E. fecalis, whereas um, meropenem doesn't act well on E. fecalis. So if you are thinking about an abdominal source, probably you prefer imipenem over meropenem, especially when you are thinking about a polymicrobial infections. The risk of seizures is much higher in imipenem. It is also there in meropenem. Especially there are some drug interactions with antiepileptics like valproate. So if you are giving carbapenem along with valproate, the valproate levels will drop very suddenly, and that can lead to a breakthrough seizure, right? So you can see in this particular study where patients were ertapenem, who used ertapenem with albumin levels of less than 0.25, less than 2.5, they had a very significant higher mortality compared to the patients with no hypoalbuminemia, whereas this difference was not seen in other carbapenems like imipenem and meropenem. And here you can again see that the rapid drop of valproate levels after starting meropenem. There is a 60% drop in within 24 hours. You might think that you will increase the dose of valproate, but dose escalation is ineffective. So you have to either change the antibiotic or probably change the anti-epileptic agent. Let's move to another case, Putum culture Pseudomonas aeruginosa. It is an MC producer, right? It is a ceftazidime resistant and cefepime susceptible. So we discussed about three important mechanisms of resistance in Pseudomonas. One is PDCs, Pseudomonas derived cephalosporinases, OPRD, loss of OPRD, and efflux pumps, MAX-AB, OPRM. So in this particular case, this is AMC producer, like it is a Pseudomonas derived cephalosporinases. So we can actually use a cefepime, or we can also use something like a BLBLI, piperacillin-tazobactam. Piperacillin-tazobactam, again the lung penetration is not great. You can probably use carbapenem also. So if you want to spare carbapenems, probably you have to go with the cefepime. There is a problem with Pseudomonas as such. So when you're looking at the clinical breakpoints for resistance, you usually, the logical thinking is Pseudomonas doesn't have a lot of porin channels. It has multiple mechanisms of resistance. So we will think that the clinical breakpoints will be lower compared to other bacteria. But you can see here the clinical breakpoint for susceptibility and resistance in Pseudomonas are quite higher, even for piperacillin-tazobactam, cefepime, for that matter, meropenem. For other enterobacterals, less than 1 is susceptible, but in Pseudomonas, even less than 2, you consider it as susceptible. So this goes against what is the common logic, right? But the thing is, the epidemiological cutoffs of Pseudomonas are in general are high. So if you keep a very low breakpoint, most of the Pseudomonas isolates will be resistant to all these antibiotics. So basically, you are increase the clinical breakpoints with the thought process that probably you can achieve these drug levels by giving higher dose of antibiotics. So that is the reason why in Pseudomonas treatment, the dose of cefepime will change. So you are not going to give a 1 gram BD, 2 gram BD dose. For Pseudomonas, I think one should give 2 gram Q8 hourly doses. So especially if the MICs are between 4 to 8, it is always better to give 2 gram 8 hourly doses over prolonged infusions. So 2 gram Q12 hourly dose in 1 hour is 2 gram Q8 hourly doses infused over 1 hour are worse than 2 gram Q12 hourly infused over 2 to 3 hours. So if you are giving higher dose, make sure that you are giving it in a little bit of prolonged infusion as well. Okay. So one of the problem with cefepime is especially if you are using Cefepime-enmetazobactam, where cefepime 2 gram Q8 hourly you are using for UTIs. I think there is all the reason why one should be using 2 gram Q8 hourly of cefepime rather than using 1 gram or 2 gram BD. So cefepime has a GABA antagonism. It can really cause encephalopathy. Many of the beta-lactam antibiotics can actually cause encephalopathy with different mechanisms. Ceftazidime can increase the quinolinic acid levels in the brain, which is again neurotoxic. So if the patient on cefepime or ceftazidime, they are looking little jittery, then one should think about a possibility of drug-induced neurotoxicity, which is very difficult in the setting of many metabolic complications and sepsis in a patient to label something as drug induced. But in case of cefepime, especially in the patients with renal dysfunction, one should have a very close eye for any development of neurotoxicity. Let's move to another case. This is an Acinetobacter, which is carbapenem resistant. We have discussed about the mechanisms of resistance. If you are thinking about enzymatic degradation, probably OXA 23, 24, 51, and 58 enzymes are very important for Acinetobacter. In India, again, we have thought we have learned that more than 50% of the cases can also produce NDM carbapenemases. So this is a carbapenem resistant Acinetobacter. We are left with very few options to treat this. We'll be discussing more in detail about management of carbapenem resistant infections. But at present, in India at least, we are using a combination of polymyxins with either Tigecycline and minocycline. So let us look into polymyxins. So there are two important polymyxins we have: colistin and polymyxin. Polymyxin B and polymyxin E. Polymyxin E is nothing but colistin. So the mechanism of polymyxins is not inhibiting peptidoglycan layer. So it's not going to act on any penicillin binding proteins. Rather, it is just acting on the surface. So it acts on the lipopolysaccharide. It will have a detergent action. So it displaces the cations from lipopolysaccharides, and that lead to a disruption of membrane integrity and leakage of cell contents. So the mechanism is very clear. It is like a detergent on the surface, but again, the polymyxins are associated with so many side effects. So these are not a new group of drugs. Polymyxins were there in 1970s, and we stopped using polymyxins because we have multiple alternative antibiotics which are much safer. But because of the drug resistance, now we had to go back and use polymyxin B and colistin in our routine practice. Polymyxins again have a little bit of anti-endotoxin effect because they are binding to lipopolysaccharide, but the clinical doses we give for the treatment of carbapenem resistant infection is not good enough for an anti-lipopolysaccharide action. But this is exploited in extracorporeal therapies like toromyxin beads, where you use polymyxin coated fibers to absorb endotoxins in extracorporeal circulation. So we have two types of polymyxin. One is colistin and one is polymyxin. The problem with colistin is colistin comes as a base, colistin sodium methate. So it's a prodrug. So the moment you give the colistin, it is not active. It takes some time, at least 6 hours for it to become active. Whereas polymyxin, your polymyxin B, you are giving not in a prodrug form, you are giving it in active form. So the moment you give, the active form is there. So it is little rapidly acting. You are gaining that 6 hours of using right antibiotics if you are using polymyxin compared to colistin. The other issue with colistin is the moment you infuse colistin, there is a competition between the tissues and kidneys to take up the colistin, and kidneys always win. So the moment you push colistin into the circulation, it is going into the kidney and getting excreted in urine. So it's very difficult to achieve right PK/PD with infusion of colistin. Whereas polymyxin, the excretion is non-renal, A little bit of hepatic uptake is there, but even in stools you will not find much of polymyxin. So polymyxin actually gets absorbed into the muscles. So polymyxin will have a more neuromuscular weakness. The moment you load someone with polymyxin, the you can actually go and ask the patient, how are you feeling? He will say that I'm feeling very weak. So polymyxin is very tricky, especially if you are using a patient who is in respiratory distress on oxygen. The moment you load the polymyxin, patient can land up in neuromuscular weakness and type 2 respiratory failure. Sometimes can have a cardiac arrest as well. So polymyxin causes more of a neuromuscular weakness, whereas colistin causes more of a kidney injury. But polymyxin can also cause kidney injury. They are not mutually exclusive, and colistin can also cause neuromuscular weakness. The dosing for colistin is little tricky. You have to renal modify it. One of the easier formula which I have learned from one of the teacher is calculate the colistin dose in MIU, always million international units, and the dose will be creatinine clearance by 10 plus 2. So if the patient's creatinine clearance is 40, so the colistin dose will be creatinine clearance by 10. 40 by 10 is 4 plus 2 is 6. So 6 units per day. And if the patient is undergoing dialysis, you add 2 more units post dialysis. So that is the dosing of colistin. For polymyxin, the loading dose is something between 20,000 to 25,000 international units per kg loading, followed by 12,500 to 15,000 international units per dose, 12th hourly dosing. So polymyxin doesn't require renal modification. So that is one of the reason why you cannot use polymyxin B for UTIs, because it is not going into the kidney. So the only indication where we prefer colistin over polymyxin is definitely patients with UTI. In all other situations, both colistin and polymyxin are equally good, but polymyxin has a better PK/PD advantage compared to colistin, even though the comparative studies with colistin and polymyxin are failed to show any significant mortality benefit with polymyxin compared to colistin. We generally prefer polymyxin, if not for the reasons of efficacy, for the ease of administration, we prefer polymyxin over colistin. Now there are a lot of interest in polymyxin resistance. So the polymyxin resistance can happen because of the alternation in the lipopolysaccharide. So if there is alternation in lipopolysaccharides, that can decrease the binding of polymyxin and it can become resistant. But again, this is associated with fitness cost for the bacteria. So most of the times we don't see polymyxin resistance, but there is increased incidence of polymyxin resistant in the recent times. One of the problem with polymyxin is you have to do a manual microbroad dilution. Vitek, which is again microbroad dilution, but automated microbroad dilution method is not very accurate for polymyxin susceptibilities. So that is the reason why you don't most of the times people won't report polymyxin susceptible or not. The third thing is the PK/PD of polymyxins are so bad. So for polymyxin to be effective in lung infection, the area under curve to MIC ratio should be something between 500 to 100, 50 to 100, and that is almost impossible to achieve that area under curve with the max doses of polymyxin which you are giving. So that is one of the reason why you don't label polymyxin as susceptible anytime. So at the best you call it as intermediate. So it is just a linguistic thing. The idea is to re impress on us that the polymyxin is a last resort antibiotic, and it is not a great antibiotic. The efficacy is going to be low. So only if you don't have any other alternative treatment, you go for polymyxin. So there is nothing called susceptible to polymyxin. Either it is resistant or intermediate. Intermediate doesn't mean that you in this context doesn't mean that you increase the dose of polymyxin to treat the patients, right? And the worry is with MCR1G. This is a plasmid mediated polymyxin resistance, and we are seeing emergence of MCR1G mediated resistance to colistin in recent isolates. That's the reason, one of the reason why polymyxin or colistin are not given alone anytime. So we usually combine with a high dose sulbactam, or we combine it with minocycline and tigecycline. So we discussed about minocycline and tigecycline. Minocycline is more prone for TED-B efflux pumps, whereas tigecycline is more prone with R&D efflux pumps. So there can be minocycline susceptibility, tigecycline resistance, and vice versa. They both have a great spectrum. For example, if God comes to you and give you a choice to choose an antibiotic which will work on all the bacteria, aerobic, anaerobic, gram negative, gram positive, and has an excellent tissue penetration, goes into all the tissues, then probably it will be tigecycline. The problem with tigecycline is that it penetrates into all the tissues so much that there won't be any blood levels of tigecycline. So if there is any bacteremia or high load infections like pneumonia or meningitis where you expect some subclinical bacteremia, tigecycline is going to fail because you don't achieve good blood concentrations of tigecycline. Tigecycline, again, because it is a glycycline with a large molecular weight, it has a poor blood-brain barrier penetration when if you compare it with minocycline. Both have equally bad blood-brain barrier penetration, but if you are comparing head-to-head with minocycline and tigecycline, probably you will prefer minocycline over tigecycline if there is a CNS infection. One of the problem with tigecycline is again side effects of tigecycline. The moment you start the patient on tigecycline, you have to keep an eye on liver function tests and coagulopathies. So this is called TIC, tigecycline induced coagulopathy. So usually with a prolonged administration of tigecycline, patients can develop thrombocytopenia and hepatitis, cholestatic type with a prolongation of PT and APTT. Everything is reversible after once you stop tigecycline, but in a clinical scenario it might really mimic like a disseminated intravascular coagulation with worsening infection. So this is very important side effect to recognize. If you are infusing tigecycline to any patient and you try to talk with the patient about immediate side effect after tigecycline, patient will complain about nausea. So tigecycline is very nauseating, and this nausea cannot be brought down by giving something like ondansetron. So tigecycline is preferred on full stomach rather than empty stomach. Nausea is one of the significant side effect with tigecycline. Whenever we are dosing tigecycline, it is always better to give a high dose tigecycline with 200 mg loading with 100 mg Q12 hourly doses rather than 50 mg BD doses, because 50 mg BD doses, especially for pneumonia, are associated with a very high risk of mortality. It will have 5 to 25 times higher mortality compared to 100 mg BD doses which we are giving. So this is about tigecycline. Minocycline is very similar to tigecycline. It is prone for TED-B efflux pump. So uh, but however, for R&D efflux pumps, tigecycline is more substrate than minocycline. Minocycline is a smaller antibiotic, has a better penetration into the wall. So the synergy with polymyxin is actually better with minocycline compared to tigecycline. So if you have a patient with minocycline susceptibility, polymyxin plus minocycline can be a great combination of treatment for this bacteria. Unlike tigecycline, it will have some blood levels. So minocycline can be used in the presence of bacteremia. Minocycline on long-term use can actually lead to skin pigmentation or tongue pigmentation. It can also cause hepatitis. It can also cause drug-induced lupus with predominant hepatitis. These are all side effects which we can always monitor. The dosing of minocycline, now it is recommended to increase the dose to 200 mg Q12 hourly doses rather than 100 mg 12 hourly. Because most of the times minocycline is labeled as susceptible if the clinical breakpoint is less than, if the MIC is less than 4, but many of the times with the drug doses which are giving of 100 mg BD, the trough levels will be less than the clinical breakpoints. So you can either choose minocycline or tigecycline. Coming to fosfomycin, fosfomycin is again very antibiotic with very different mechanism of action. It inhibits the MUR-A enzyme, which is the enzyme which is required for the first step of synthesis of peptidoglycan. So eventually, fosfomycin is targeting peptidoglycan layer. Fosfomycin is basically approved for treatment of uncomplicated UTIs like cystitis. We give it in the sachet form, 3 gram sachet, stat dose or probably alternate day for 3 doses. So that is what it is approved for. But in India, systemic fosfomycin, intravenous fosfomycin at very high doses, ranging from 16 to 24 grams, nothing less than 12 grams, is very very common to use, especially for the management of Carbapenem resistant E. coli. So we'll be discussing it in more detail. But once you are using fosfomycin for treatment of systemic infections, there are few side effects one should be aware of. Fosfomycin, if you are using 20-gram dose per day, it will approximately have 10 grams of sodium. So that is a lot of sodium for a critically ill patient. Patient can actually land up in fluid overload and heart failure in hospital because of fosfomycin. So it is very important to monitor whether the patient is developing fluid overload or not. And one can probably add diuretic, but one has to be very sure that there is no hypernatremia. So avoid diuretics like Lasix, which has a negative free water clearance, so it can actually worsen the hypernatremia in patients with fosfomycin. Probably using thiazide diuretics can be a great choice for these patients, so that you can bring down the sodium a little bit, and at the same time you can prevent the fluid overload in these patients. So the another side effect which can happen with fosfomycin is hypernatremia. So in normal patients, if someone is developing hypernatremia, they will thirsty and they will drink water. But a patient who is intubated in the critical care with a lot of sedation going on, they can develop hypernatremia. In critical care, it is very important because hypernatremia is a very strong stimulant for thirst. So despite of no amount of sedation, if patient is developing hypernatremia, he will be very thirsty, and he cannot communicate that with you. So he will be struggling, and then you see the patient ventilator asynchrony, and you will sedate him more. Probably you will give more muscle relaxants as well. So that will eventually lead to a poor prognosis of the patient. So it is always important to keep an eye on sodium, so that there is no hypernatremia, to prevent patient ventilator asynchrony as well. More the sodium in the body, more the aldosterone activity, and there is a risk of hypokalemia because of hyperaldosteronism. So these are the things which commonly happens with intravenous fosfomycin infusions. It has a very specific indication because fosfomycin is found to be active against carbapenem resistant E. coli, even with mutations in penicillin binding 3, binding PBP3. So we will be discussing more in detail, but one should understand the side effects of the systemic fosfomycin in general. I hope you people have enjoyed this session. We'll be discussing more about carbapenem resistant infections in the coming session.